culinary medicine specialist. I am going to be joined by Dr. Rocio Salas-Wallen, who is a triple board certified internal medicine physician, obesity medicine specialist, and endocrinologist, who is focusing her practice on women's hormone health. She practices in New York, and we are going to be discussing women's weight help with it. So I just hit the accept button. Sorry. And I know so many of you are so excited. We try to do this. There she is. Okay, so let's start over real quick. Introduce yourself again.
So I'm an endocrinologist and obesity board certified physician practicing in Manhattan in New York City. And I focus more into women's hormonal health, premenopause, menopause, PCOS, and weight gain, obesity and weight loss.
Okay, so we have lots and lots of questions to dive into. Really great, interesting questions. Where I want to start is a lot of people are told that, or don't understand that, a lot of the weight gain associated through the menopause transition has a hormonal component, especially when we look at body composition changes. Can you talk about the intra-abdominal fat, visceral fat, and,
Yes.
and going on hormonally?
So approximately women after 40, they gain about 1 pound per year. And this is multifactorial, as is weight gain and obesity in general, right? But talking specifically at this period of a woman's life, it's the drop or the fluctuating levels of estrogen, right? That we're starting to see in premenopause and menopause. And the drop of estrogen promotes visceral fat. The visceral fat promotes insulin resistance, and this promotes more visceral fat, and it just becomes a vicious cycle. So definitely with changes in estrogen, the decline of estrogen, we see increase in abdominal fat, increase in weight gain, and changes in the body distribution, right? Added to this, in midlife, as we age, our metabolism slows down because we naturally lose muscle. And this muscle loss is what causes that slowing down of metabolism after a certain age. So the drop of estrogen, aging, slowing down of the metabolism, losing muscle, lifestyle, right? Mood or symptoms of premenopause and menopause that may make it difficult for the woman to exercise if they have depression, mood disorders, right? So all that combination is really a recipe for weight gain during midlife.
So would you say that, kind of the tipping factor for a lot of this is when we begin to have the hormone changes associated with perimenopause? Would you agree
Definitely.
with that? And that this kind of sets us up for failure on multiple levels.
In every,
because
yes.
go down, sleep gets disrupted, also at this time of our lives, ailing parents, teenagers, late in life babies, marital issues, it's like the
work
kind of comes together to make it really a struggle for patients. So can you talk about, I can talk about it, but have you seen in the role of hormone therapy as far as weight gain and more to do with body distribution changes?
Yeah, definitely. So when we put a woman in estrogen during premenopause or menopause, we never promote it as weight gain, right? It's not a weight gain per se, but it will change again the body distribution, right? That accumulation of visceral fat, that we can talk about visceral fat, and visceral fat is what we call the bad fat. It's pro-inflammatory, pro-cancer, right? It's increase of cardiovascular disease, metabolic disease, type 2 diabetes. So putting a woman on estrogen changes the body distribution to decrease visceral fat and abdominal fat, right? Also, putting a woman on estrogen can help build the muscle that we're losing naturally, and it slows down our metabolism, right?
So we see it kind of a shift. You still have to, the way I explain to patients, it's not a magical weight loss medication. It's going to make your body work more efficiently as it did pre-menopause, so that your nutrition efforts, your exercise efforts, your sleep, your stress, all the things in our toolkit that we use as physicians to help you stay healthy are going to work better for you. But I think the elephant in the room is going to be the introduction. I mean, they've been around forever, but the kind of sudden social surge of the GLP-1 type medication. So I'm going to read you, since you are the expert in this area, this is what you do all day, every day. I'm going to rely on your expertise to answer some of these questions. So can you lose weight without the GLP-1? Oh, first of all, what is a GLP-1 agonist? So,
Okay, so GLP-1 agonist is a hormone that GLP-1 are hormones that we make in our gut, in our small gut. And what we see in the market, what we're seeing semaglutide, tirzepatide, they're synthetic versions of the hormones that we make, and they control appetite by targeting the two reasons that we eat. We eat for survival and fuel, and we eat for our reward, right? So for the survival fuel part, it increases your satiety hormones and decreases your hunger hormones in between meals. So you're really content and satisfied with half of what you normally would eat. And then in the amygdala area, in the hedonistic eating and drinking, it removes the anticipation of our reward. So imagine like anticipating a glass of wine at night. You're going to feel relaxed. You're going to have some conversation. So you're anticipating a reward. It could be alcohol. It could be food. These medications, these hormones, remove it. So you eat when you're hungry. You enjoy when you're eating, but that's you're not anticipating or waiting for any emotional stress, social reward.
so there were a few questions about that, specifically talking about alcohol, shopping addiction, gambling. Are we seeing a decrease in those dopamine driven behaviors or dopamine release? You know, you do the behavior, you get a dopamine release, which is the reward our brain gets. Are you seeing that across the board
I
with?
would I would say definitely with alcohol. I think that's the next after appetite and eating. It's definitely alcohol consumption,
Okay.
right? I feel like, and it's being studied right now for alcohol abuse too. So I can clinically say, by my experience in my patients, that many of them decrease their consumption of alcohol. And when you think about it, alcohol also contributes to calories. It disinhibits you when when you start
Mhm.
eating, right? So just that also helps with the weight loss too.
Okay. And then a lot of questions around, and this is really a big topic on social media and something I discuss with my patients as well. When we talk about the risks and benefits, I have a handful of patients on semaglutide or tirzepatide, and with very close monitoring of muscle mass, and a lot of there's a whole industry that's been built around calories in, calories out, and shaming women, especially into you're having a weight problem because you're lazy and you're not doing enough. And so they're really coming under fire. They're really attacking these medications because I think it's cutting into their bottom line. I wish they'd work with the women, because we still need to learn how to move our bodies in a way
Definitely.
healthier, instead of being so antagonistic about the medication. But can you discuss the worries around lean muscle mass loss?
So I like to tell to my patients, and like in my social medias, the weight loss medications do not replace a healthy lifestyle, and a healthy lifestyle does not replace the weight loss medications, right? I think together we can finally, the lifestyle choices and the lifestyle changes can really come and shine through with the use of the weight loss medications. In regards to muscle loss, so there's no a direct effect from this hormone that can affect muscle and cause muscle loss. Muscle loss happens with any caloric restrictive diet. It could be Atkins, it could be any of those diets out there that you're going to decrease your caloric consumption. The first thing that we tend to cut is protein, because protein is what makes us feel the fullest and the more satisfied, right? So whenever you're on a diet or eating less, you cut back protein. Because of that is when we start losing muscle. That's number one. Second, it's when, and I want to say this now, is the efficacy and the safety of the drug depends on who's giving you this medication. So
Mhm.
if you go to the right doctor who's going to be doing body composition and not going by the number in the scale or the BMI, you won't lose muscle because you'll be seeing what is it that you're losing. Whenever somebody's pushing for high numbers of weight loss per week or per month, you're going to be exposed to muscle loss, right? Whenever you're just going by the scale or the BMI, you most likely are going to be losing muscle mass without knowing. So weight loss as a medicine, it's new, right? We are figuring it out as we're doing it, and I we had it very wrong. We were just watching the scale going up and down, but it's really very complex to get the patient to the right place. Otherwise, if we're not doing body composition, if we're not measuring muscle mass, we're gonna make patients skinny fat. Right, they're just losing weight, but they're losing fat and muscle, and at the end, they may be not metabolically healthy, even though they might have lost 40 pounds. That is the main problem. Is really, and this is why I like to educate the public, because they can advocate for themselves whenever they go and see somebody for these medications. If they're not talking to you about preserving muscle, about protein in your diet, then you should definitely try to find somebody else.
How that's a question I'm seeing pop up is how do you find a provider when every med spa on the corner seems to
Yeah.
be offering
Yeah.
medications? What would be some guidelines you would suggest for someone to lose, to find a provider who's going to guide them through this process in the healthiest way?
So definitely, they can go to the American Board of Obesity Medicine website, abom.org, and then you can search for a provider, an obesity board certified physicians in your area. Whenever you are asking a doctor for this medication, ask them about their experience. Ask them how many patients are they treating to that. Ask them what's their success rate. Ask them why have they had to stop the medication. Ask them what other measurements besides the scale do they use for the weight loss, right? Are they going to be talking about muscle? How much weight are they promoting, or how much weight are they promising you to lose? Really, it should be 1 to 2 pounds per week in a healthy way, right? So I feel like there's certain things that a patient can be in the lookout to see if it's the right fit for them.
Some questions around protein intake. Do you have guidelines that you suggest to your patients for adequate protein intake through this weight loss
I
process?
mean, definitely what I've seen in all the body compositions that I perform, protein is a must to preserve muscle. Right? Whenever patients ask me, oh, about exercise and this, really, if you maintain an adequate protein intake, you will save muscle. But if we're talking that you also have to build muscle, then definitely weight training, resistance training is important. I go by the patient's weight and their patient's muscle mass when I'm doing their body composition. So it's very
Thanks.
individualized, right, on what's going to be their protein intake. But on average, if I'm going to go like ballpark, anywhere from 90 to 100, 110 grams of protein. But again, I'm speaking very broadly. I do it more
Same.
individualized.
Same, but it tends to be in that range. And if she's 5'11" and and has
Exactly.
tremendous, it might be 120. If she's 4'11",
Exactly.
it really for
Maybe
her
80. Exactly.
body type. Here's the question: can you use menopausal hormone therapy and GLP-1 medications together?
Yes,
Yes.
definitely. I think it's a great combination of that will help get the woman their quality of health that they deserve at any age, right? But somehow we attribute that at this age we don't deserve, like, oh, it's okay, now we're here, I live my life, right? Like we give up so easily. But it's really a great combination to use. There's no contraindications, there's no interactions between them, bottom line.
What about there's some new, I think berberine or some of the supplements that are having GLP-1 like effects. Can you comment on those? That was another question.
So definitely, we're not going to see 100-pound weight loss on Burberry, period, right? Uh, does it help to regulate? May you lose 3 pounds, 5 pounds here? I think it's the same as metformin, right? Like, yeah, maybe it may help, but we're never going to see the results in weight loss that we see on incretins, on
On
GLP-1.
incretins. Okay. Can you talk about the side effects of some of the incretins and what you can do to navigate those and changing medications?
So definitely going slow on the doses, right? I feel many times patients and the doctors want to go up very quick on the doses just because they're there. But you really have to let the patient, or the patient has to tolerate one dose with no side effects, ideally, before they move to the second dose, because we're not going to give the medication the best chance that it deserves, right? When we try to go too fast. I think hydration is important. This medication is called dehydration. I would say that dehydration is the hardest side effect on patients, and it sounds simple, just drinking water, but it's really the side effect that is going to take the patient down. Basically, they're going to feel extremely tired, fatigued, with no energy, and this is purely dehydration. They're not having low sugar because those medications don't cause hypoglycemia. They're still eating some calories, sufficient calories. Is more going to be dehydration. The nausea, we're seeing it more with semaglutide. We don't see that anymore with tirzepatide. You know, I like to say that tirzepatide is the iPhone 15 of these drugs, and every time they're coming more sophisticated, more safer with less side effects, right? So definitely we see less gastric side effects with tirzepatide than with semaglutide.
Okay. Lots of questions around, can I ever get off of these medications? What's a safe dose to continue? Is this something I might consider for a lifetime?
And again, it's going to be very individualized, but let's say patients that have struggled with weight since childhood, since teenage years, right in their 40s and their 50s and their 60s, that have struggled with their weight for decades, there's less likelihood that they can maintain the weight loss without some sort of dose, right? My goal is always the lowest dose possible long term.
Long term.
If it's somebody that's always been healthy, never struggled with weight, and somehow in midlife or something happened, then there's a higher chance that they don't require the medication long term. But it just depends on the history and their weight history of the patient in
Okay.
particular. Definitely the best bet to either maybe stay off the medication or require the less dose possible is muscle mass.
Okay. Good to know. How often would you recommend resistance training, muscle training? How often do you recommend to your
I think
patients?
a minimum of 2 days per week, and I try to be very conscious of the lifestyle of the woman, right? Like myself, if I get in the gym twice a week, I feel happy. If I get a third day, I'm happier, but I don't beat myself up. So small goals that will be able to maintain at least minimum of 2 days.
Oh, this is a good question. I know the answer, but HRT and diabetes, is there any negative impact?
No,
Fine.
actually, because of the drop of estrogen, there's increase of the risk of type 2 diabetes in postmenopausal women because of that increase of the visceral fat that causes the insulin resistance and the hyperinsulinemia. So actually, it decreases visceral fat, increases insulin sensitivity, and there will be a benefit in glucose in the postmenopausal woman or premenopausal woman on HRT.
Um, because of the shortages, a lot of people are turning to compounding for the medications. Is this something you are in favor of, or what is your prescribing
My
preference?
prescribing preference is FDA regulated medications, right? Recently, the Obesity Society, the Obesity Medical Association, the Endocrine Society, the Bariatric Surgery Association came with a consensus, a joint statement against the use of compounded semaglutide because there were being seen a lot of side effects, a lot of calls to toxicology from using compounded medication, because when you get the compounded drug, it's very self-patient administered and the patient can overdose, right? It doesn't happen with the other, with the FDA pens that we have, right? So there's, and it's not as regulated. We don't really know what is it that you're getting. So it's more risky.
Okay. We, on my end of the world, same. So, and okay, so there's a lot of misconceptions. I'm seeing probably a personal trainer saying most of the weight loss in Ozempic is muscle mass, probably not a sudden plan who's using it just to lose 30 pounds or less and is also in menopause and experiencing perimenopausal symptoms. This to me sounds like personal bias.
So, yeah, I want to say something to all the personal trainers out there. We're not going to steal patients. We're not going to steal clients. We actually, now with this, we need them
Need
the most.
to do the most.
We
Yeah.
need you the most. We need your help the most. I've never referred so many patients to personal trainers as I do on weight loss medications,
Same.
because we have to work together on maintain, and our goal is the same, muscle mass, right? It's not, again, the right prescriber is going to be watching more muscle than anything else. So our goal at the end is the same, to make the patient metabolically healthy.
Exactly. I'm reading comments. So you guys, we have a question box on the bottom of my screen. There's a little circle with a question mark. So we're going to get to a few more, but I want to answer your questions live. So put your questions down there and we will get to them. Oh, can you take ADHD meds and the incretins together?
Yes, they definitely, because the incretins don't cause, they're not stimulant uh, to begin with, so they don't cause weight loss by stimulating like HGAD medication. So there's no contraindication with or interaction with the drug.
Okay, good to know. What about interaction with thyroid medications? I'm assuming the same.
None. Now, people have to be careful about, and this is will be the doctor that is prescribing when there's so thyroid hormone is weight based, right? So we dose a patient according to their weight. So if there's more weight, they need a higher dose. If there's less weight, they'll require a lower dose. So let's say somebody who has hypothyroidism and is a levothyroxine 100 micrograms and they lose 60 pounds, their dose need to be adjusted, right? They may need less hormone because their body surface is smaller. So before they become hyperthyroid, we have to check their TSH levels frequently.
Okay. What's your opinion? Is every woman going to need hormone replacement therapy in her life?
I mean, I would say that there are very few people that won't. And I'm like, I don't think there's absolute contraindications anymore about HRT as we used to think, right? In blood clots and all of that. I don't really think that there's an absolute contraindication, even in patients that have history of breast cancer,
Yeah,
that they themselves have history of breast cancer. I, I think it's important to always discuss the pros and the cons of them, right? But even in those patients, sometimes I have patients that tell me, if I'm going to live 20 years only, I cannot live 20 years like this,
right.
just if the breast cancer is going to come back, right? So it's, again, it has to be a very informed decision.
What do you recommend? This is a great question for osteoporosis prevention.
Weight-bearing exercises, having a normal vitamin D,
Mhm.
right? A normal weight, not smoking, not too much alcohol consumption, hopefully none. And then do your bone density and then if your mother had a history of osteoporosis, then you really have to be very proactive, right? But I think those are the most important things.
Hormone therapy is FDA approved for the treatment of osteoporosis, and it's preventative. It's preventative.
That's preventative, definitely. Yeah.
Okay, good to know. Let me see let's see. Can you talk about the safety of GLP-1 agonists in general? Someone asked that.
They're very safe. As prescribers, and I'm sure this is your same idea, is whenever we give a medication, whenever we prescribe a medication, is because we know their benefits outweigh the risks, right? So it's the same thing with this class of drugs. And another thing that I think it's important to clarify is that they're not new drugs. The first one was developed in 1994, and the first FDA approved was in 2005. So we have almost close to 30 plus years of data in their safety. Again, those complications will probably be more prescriber cost.
Okay. Okay. Let me get to the questions. Okay, share the website again to find a obesity medicine specialist.
abom.org.
Okay. Um, I'm not going to read that. What should estrogen levels be at?
So when we put up, and I feel like I'm being tested
No.
now. So no, we go by symptoms, right? Like where we're trying to aim whenever we put a woman on hormone replacement therapy is to fix their symptoms, right? To improve their sleep, to improve their vaginal dryness, to the hot flashes. But we don't really measure estrogen levels when we put someone on hormone replacement, unless it's premature ovarian insufficiency. That's the only time that we do want to aim for those premenopausal estrogen levels of around 200. But in premenopause and postmenopause is more symptom related.
Right. I'll occasionally draw them on a patient I'm worried is not therapeutic on her dose. And I've kind of run out, I'm at the top level of the patches or something. She's still symptomatic. I will then get it because maybe she's not absorbing, but I don't routinely do them because we don't have therapeutic ranges.
Exactly.
you could feel amazing at 50 and I could still be horrible and need more medication. So I'm not going to gaslight you and say, well,
Exactly.
your level should be fine. You shouldn't be having symptoms. That's part of, the problem we have with
Yeah,
women in medicine. Can you talk about premature ovarian failure, surgical menopause, women who go through menopause before their time is due? This is something lots of people have been reaching out to me recently. I guess they found me, the POI community, and have thanked me for spreading knowledge and awareness. I wanted to give them some time here to talk about
definitely.
goes through menopause really before the age of 40 for whatever reason, or before, that article came out this month, I believe, looking at increase in mortality for
So
women who were not started on hormone therapy, whose ovaries were removed, and how detrimental that is.
So women that go through the estrogen level decrease before the age of 40, that they go pretty much into menopause before the age of 40 is what we call premature ovarian insufficiency. We're not trying to say failure anymore. Insufficiency. It's an autoimmune disease for the majority of patients. So they're born with antibodies that will destroy the follicles in their ovaries, that they will stop producing estrogen. The earlier a woman stops making estrogen, the higher the mortality, right? The higher the cardiovascular mortality, higher risk of dementia, higher risk of osteoporosis, higher risk of loss of muscle mass, higher mortality and all-cause mortality. So it's really important at that age, and that's we talk back at the levels. Here is what's really important, that we really target premenopausal levels of estrogen, because the woman, she's younger, so she's going to have more years of possible side effects and complications. So we really want to prevent that by giving them sufficient estrogen, as much as they should be producing, right? And in this case, also testosterone
Yeah.
may play a role, because we make testosterone in our ovaries, right? So I know testosterone, the guidelines
Or
right now, they're
premature.
more to premenopause and menopause, but definitely for the woman with premature ovarian insufficiency, testosterone plays a role too, and we should offer testosterone to the patients too.
Okay, back to incretins. Why does Ozempic work for some but not for
So, I have close to 3,000 patients on these medications, and I don't find that some patients respond better than the other ones. I think it's their eating habits, what they're eating many times. Whenever I see, really, these medications work so well, but the only time that I've seen that don't help to lose weight is when the patient is still eating a very high, dense caloric diet, right? So yes, they may be eating half of what they normally would be eating, but they're still eating 2,000, 3,000 calories a day. So they're not going to lose weight. And we will never catch up, even throwing 2 medications, 3 medications to what they're eating. So definitely it's more to do with the habits of that person than working for some or not. Now, there's some genetic diseases that can cause obesity that are missed in childhood, that the ones that are not very severe. And those patients that they're eating healthy, that they're doing everything, that they have accountability, that you have them on max doses and they're not losing weight, they should go be tested for genetic testing, which is a swab to see if they have any mutation of obesity that they will require a different medication.
Okay, good to know. A good question. There's a couple of people asked, they had gastric bypass or Roux-en-Y or different gastric surgeries years ago, did great until menopause, and now they've gained the weight. Are these medications safe for these patients, status post abdominal surgery, whichever
Yes,
one?
yes, and yes, and it's it's sad to think about bariatric surgery having these medications, because what bariatric surgery does, it constricts you, right? It restricts how much you can eat. So you may want to eat more, but you can't. The medications, the incretins, they remove the reward, they remove the wanting of the food, which bariatric doesn't do. So really the drive is still there, but they can't. Eventually they overrun that effect and they start gaining weight. But it's really some sort of torture to the patient, because they still have the drive, but they can eat.
Hmm.
With the medications, they don't have the drive anymore. They don't have that and that looking for that reward. So really, I think we're going to be moving away from bariatric surgery. They may still be the patient that may benefit from it, but this medication surpass what bariatric surgery does. And patients, I have many patients that have lost over 100 pounds on the medications without need of surgery.
Okay.
But for
Uh,
your questions, yes, they can be used for patients that had bariatric surgery.
okay. Um, can you start any hormone therapy during perimenopause?
Yes, of course.
Of
Uh,
course.
I mean, we don't have to wait for you to feel and to have all the laundry symptoms, right? I mean, it's definitely. I'm more proactive. I'm more preventative. I like to be ahead 10 years before something happens to, same with weight loss to prevent cancer, to prevent osteoarthritis. It's the same concept, right? I think at the age that the patient starts having some sort of symptoms, and especially for me, the ones that I want to improve immediately is sleep. I feel like sleep's so important. So if I have a patient that is waking up at 3 4 a.m. in the morning and she's 43, 44, I have this discussion with them, right? Because we don't have to wait until you're closer to menopause to start hormone replacement therapy.
So, what I want everyone to understand, because we have a ton of viewers, which is amazing, um, just this last month, the British Medical Journal posted, they have this huge registry in Great Britain, and they pulled out data on, they pulled out the data on whether or not someone was on hormone therapy plus the age of menopause. Like they looked at the lifetime exposure to estrogen, and which meant last period for minus first, last period minus first period, that many years plus time on HRT. And they looked at dementia. And the more your body is exposed to estrogen in any form, the much lower the chance. It's like this crazy line, chance that you will develop dementia. And so that's what I want people to understand is, waiting till you're fully menopausal, by definition of your last period, which is ridiculous, by the way, that we define it that way. But, you're getting a gap year there with no estrogen, which is allowing these diseases to, the inflammation to start and these diseases to build up. And I'm sure it's the same database. They're going to pull out cardiovascular disease. They're going to pull out diabetes. They're going to pull all these things out and be like, oh my
Yes.
God, estrogen is so protective. So starting as soon as possible, we know for mental health, starting in perimenopause, we decrease your risk of upping your medications of SSRIs. Actually, in Great Britain, they think that giving hormone therapy for new onset depression, not severe clinical depression, but for low new mood disorders should be
Yeah.
primary therapy, not
Yeah. Yeah. Not more. It really upsets me, and I'm sure it's the same with you, that I see a woman that's fully premenopausal and they put her on antidepressant, anti-anxiety medication. Like they're trying to target
still
everything
anxiety. Yeah,
except the hormone, except estrogen. And they
yeah,
don't even have that conversation. So I think it's really important for women to know this, right? So they can advocate for
right.
themselves.
Okay, let's do a few more. Are you still good to keep going? Because
Yes,
people are just okay.
definitely.
Um, let's see how to begin to have the conversation with your doctor about the incretins. What would you recommend?
So talk about weight, about the history of the weight, about what the patient is doing to lose the weight, right? Like what lifestyle modifications they're doing and that they're not working, right? And I think this is very common for the midlife women, is that everything that they were doing in their 20s and in their 30s, suddenly it's not working, and the weight keeps accumulating every year, even though they're doing exactly the same thing, right? So I feel if a patient feels that they should have seen results by the time that they're seeing their doctor and it's not happening, definitely have this conversation.
Okay. And I think doctors are becoming more comfortable with the discussion, and HRT as well. I think all this talk we're doing on social media is putting some pressure.
And
Um,
and I think that if the doctor doesn't know about this medication or doesn't feel comfortable, would not have this conversation and would not offer. So then you have to find somebody who does do this and feel comfortable, and they can do that when they call and make an appointment. Does the doctor do HRT? Does the doctor prescribe incretins? Right? Just be well informed before you even go to that doctor.
make the phone call. Some good questions around spironolactone, which we use for hair loss as an anti-androgen, but the flip side of being an anti-androgen potentially is loss of muscle mass. Can you talk about that?
Uh, yes, but I think it's not as significant versus the benefits of the spironolactone,
Mm.
right? I think there's other things that the patient and the woman can do to preserve the muscle, same as with the weight loss medications. We're not going to give weight loss medications because it can cause muscle loss. Same with the spironolactone. It has its benefits, it has its use for hair loss, for acne and PCOS, right? I can even say that it helps with anxiety and PCOS. And PCOS, we see a lot of anxiety because of the elevated androgens. I
Mhm.
see it in improvement with spironolactone. So I would say in this case, the benefits outweigh the muscle loss when we can do something for muscle loss, increase resistance training, increase protein in their diet to prevent that from happening.
Um, I can probably talk more about this. A lot of questions about frozen shoulders. So there is a study. So a study came out of Duke University that was between the Department of Orthopedic Surgery, headed by a woman, and the Department of Obstetrics and Gynecology, also happened to be headed by a woman, who got together and said, hey, there's something here. And they went and did a retroactive chart review and found that the risk of, we know that adhesive capsulitis, which is what we call frozen shoulder, it happens much more in women and definitely in perimenopause and menopause. That was established. But what they found was that women who had been treated with hormone therapy had a much lower risk of developing a new condition. If the adhesive capsulitis happens to you, you still need the therapy. You must go to PT, orthopedic surgeon, like do all the things to break up the adhesions and get that shoulder moving again. But we know that HRT is protective for you not
Yes.
this. And one of the to understand that estrogen is better at prevention than cure. Estrogen is a natural anti-inflammatory hormone in your body, especially in the bones and joints. And when we lose those levels, even with HRT, it's never going to be the same. Remember, like the best thing I could ever do is to retransplant your 25-year-old ovaries back in your body, but we don't have that option.
Not yet.
So HRT is kind of a poor cousin. It's
Exactly.
great, it's going to do a lot, but we still have to do the work. But knowing, I think just all the education that we do, that's why I love following you around, this is real, this is happening, this is what to expect, this is not your fault, we have options, these are all workarounds, lifestyle's important, nutrition's important, stress reduction, sleep optimization, community, what I encourage everyone is share your stories. But what I won't let happen is anyone to be shamed or, made to feel like they're somehow less of a person if they're just wanting to improve their health, and we have medications to help with that.
And another thing that I think is very important in women's health is
Oh,
sexual health, right? I feel like I get mind blown whenever I see a woman, and I always ask them, how is your libido? How's your sex life? Blah, blah, blah. And no, it's okay. I don't have any. It's okay. I'm not sexual. Like it blows my mind, like how we accept that it's okay. I had my kids. I'm married. Like I don't need to have sex in my life when it's so important. And there's so many things that contribute for that, for the woman to not wanting to have a healthy sex life, or to be sexually active or to be more proactive, is the weight gain that we see in midlife, right? I think self-conscious that really woman keeps them from being sexually active. The changes in estrogen, the changes in the libido, the drop in testosterone. So we can also fix those things for the woman to also have a satisfied, healthy sex life, which I think is really
let's
important.
talk about genital urinary syndrome of menopause and
All right, well, I know it's almost 1 o'clock. We'll share this out if you want to watch those last couple minutes that are, about more local hormonal treatment and not so much about obesity, but, thanks for listening today. Does anybody have any comments or questions before we sign off for the day? Oh, Dr. Spielberg asked, many of our patients cannot afford FDA approved. And they addressed the compounding. I think it must have been after the question. And there is some new legislation that I think is going to change the availability of compounded GLP-1s. I know a lot of practices were using those. So I'm not sure. I think that would be something that, you know, we could try to find some information about and share. And as far as adding testosterone, you know, she said primarily she would use it for women with premature ovarian insufficiency. I have looked before, partly because I'm in this age range and I have like lots of friends who are talking about testosterone, and there's not good guidelines that I can see as far as you know, recommendations to add testosterone. So I can't really answer that question. Yeah, we could try to get Dan Bessison to weigh in, or we've worked some with another endocrinologist. So I'll try to follow up on those questions, like what's happening with compounding and then the testosterone. But
thank you so much.
oh
I
yeah,
just like to say in our practice, we have so many patients that cannot afford, you know,
I know.
even it just so yeah, I love better data
I know.
on benefit versus risk. I mean,
Yep.
now I'm just going with a, you know, a trusted compounding pharmacy and, you know, going with whether patient is responding to it and it, you know, is improving their health. But, and if you add vitamin B12 to it, then it is, they're able to give it. So.
Oh, like because you're giving a therapeutic injection, you mean?
Yes, because the legislation, you know, now that there's no
Oh,
longer
oh,
a
okay.
shortage,
Okay.
they can't give it if it's just that. But if patient has fatigue or need, you know, they need
Other indications.
exactly. So that's kind of
Interesting.
how we're doing it now. And the
Okay.
testosterone question, I just have so many patients showing up in my office lately who are asking for it.
Me
And,
too.
you know, I haven't been able to find good research to show when I should give it to them
Nope.
and when I shouldn't. So, yeah.
No, I know. I mean, I have had like discussions with friends and tried to go figure out like what is the evidence-based approach
Yeah.
for that, and there really is not a good one. So we
But
could
it's certainly being done in a lot of
uh-huh.
boutique practices,
It
which
definitely
is,
is. And
yeah.
I had people tell me like, oh, I feel so much better. I have more energy, and it definitely
Yeah.
helps like if you have low libido, but I don't know. I don't know.
Yeah. Yeah.
So
Yeah. Okay.
well,
Well, thank
thank
you so
you.
much.
Yeah, we'll share this and you can pass it on to people.